Antenatal testing is performed to assess how baby is doing. What we're trying to find out is more time in mom going to help baby? What is the risk of keeping baby in? We do this in certain situations. We prophylactically do it in high-risk pregnancies and do it often. Or we do it in moms who have decreased fetal movement. We want to find out, did baby actually die in utero? Or is baby on its way? What I want to do is take you down the algorithm and then explore the individual tests and what you're actually looking for when you do these procedures. So when mom comes in, she's either going to be high risk or she's felt decreased fetal movement. And mom's pretty good at this, right? She's been living with baby the whole time. She expects a kick or a movement every so often. And if baby's not doing that, baby might be in trouble. So the first thing you do is a non-stress test. And I'll explain what all this stuff means after we go through the algorithm. If the non-stress test is reassuring and there are accelerations, then you can just tell mom baby's doing well and offer her reassurance. If this were done for decreased fetal movement, you can stop. Nothing else needs to be done. If it was done for a high-risk pregnancy, you're going to repeat this every week until delivery. Again, the goal is once it becomes bad enough to do something about, you're probably going to want to deliver, and you want to know ahead of time for the high-risk pregnancy. But you want to do it often so that you know baby's doing well, and as soon as baby shows signs of doing poorly, you can act on it. But if it's not reassuring and there aren't accelerations, you're going to repeat the test. You're going to do a non-stress test after vibroacoustic stimulation. You basically take ultrasound waves, a jackhammer, pound them against baby, agitate baby, and then redo the NST. Again, if it's reassuring and there are accelerations, you go to reassurance. Baby was asleep and just needed a little bit of stimulation in order to get going. But if that didn't work either, that went poorly, then what you're going to move to is the ultrasound-based biophysical profile. And the biophysical profile is very similar to an APGAR score, except it takes into account the non-stress test and the amount of fluid in the amniotic sac. It's graded on a score of 0 to 10, 10 being good, 0 being bad. If the biophysical profile is 8 to 10, doing really well, you simply go to reassurance. If the biophysical profile is of a score of 0 to 2, baby might already be dead, and if it's not, fetal demise is imminent. In this case, you don't have time to mess around, you are going to do delivery. Usually by C-section. But if the biophysical profile is equivocal, you are going to make your decision based on the gestational age. The idea being the closer to term baby is, the less benefit baby derives from being in the oven longer, and the higher the risk of fetal demise in utero. If the gestational age is greater than 37 weeks, that is term, this is simply a high-risk pregnancy, and it is worth it to get baby out. In this case, you're going to do delivery, only you're likely to do induction and a vaginal delivery. Now, I want you to realize, of course, it is not this clean, where a fetal demise it goes by C-section and equivocal goes by vaginal birth. That decision is going to be based on more than just this. It's going to be based on how severe and frequent these things are, and it's also going to be based on mom's preferences. But I want you to learn it at the foundational level that if baby has some time because they're equivocal and not in trouble, you have time to admit mom, set up the delivery, get her induced, and do a vaginal delivery, versus baby is almost dead, if not already dead, and if baby's not dead, we got to get it out because it will die. So keep these separate as different diagnoses and different treatments, knowing that choosing which method of delivery is far more complicated than this. If the gestational age is not term, less than 37 weeks, then you need to do the next test, which is a contraction stress test. A contraction stress test is done with mom having contractions. Very rarely are you going to induce contractions in order to assess baby. Most of the time, interpretation of the contraction stress test falls on you during labor. If you have fetal heart tracings and mom is having contractions, you can follow baby and find out how baby is doing. If the contraction stress test shows the absence of late deceleration and the absence of bradycardia, it is considered a reassuring contraction stress test. At this time, you're going to leave baby in, give baby more time. That is, allow mom to progress through her vaginal delivery, or leave the bun in the oven longer with tocolytic steroids and more time. But at this point, baby's doing so poorly, you're probably going to bring her in and delivery is on its way. If instead the contraction stress test shows us positive bradycardia or positive late decelerations, then fetal demise is imminent, and this is the thing that might convert a vaginal delivery into C-section. She's pushing, baby's in trouble, fetal bradycardia and late decelerations, that pushes the obstetrician to do a surgery. All right, this is the algorithm I want you to remember, and I want you to use these as discrete, different diagnoses with discrete treatments. Help you get the answer right, and you'll be able to justify yourself based on the algorithm. Now let's go through and talk about the individual tests. The non-stress test is non-stress because there are no contractions. And what you're looking at is fetal heart rate. And what you want to know about is variability and accelerations. What does that mean? This graph is going to represent the heart rate on the left and time on the bottom. Fetal bradycardia is less than 110, and tachycardia is greater than 160. I'm going to show you a couple things with this graph. So we want to be normally between 160 and 110. What you're looking for is variability and accelerations, and a heart rate in the normal range. Variability should be consistent and not that much. This is the right amount of variability that shows some change in the heart rate, but it's pretty consistent and it doesn't move anywhere. This is good variability. If you see a flat line without any variability, this is bad. This is too little variability. I've also drawn the variability with too little above 160 to show that tachycardia is not good. But at the same time, too much variability is also bad. And I've drawn the fetal heart tracing to be below 110 fetal bradycardia. This is what you're looking for. That's variability. But you're also looking for accelerations. And accelerations are going to be increases in the heart rate that is sustained for a certain amount of time in a certain window. What I want you to remember is 15-15, 2 in 20. If you have a very young fetus, it might be 10-10, 2 in 20. But what I want you to remember is 15-15, 2 in 20. What does that mean? It means we want to see good variability. But every once in a while, we want to see the heart rate rise for a certain amount of time. And we want to see this rise twice in 20 minutes. So in this time span, from 0 to 20, we want at least 2 of these attempts at acceleration. And the 15-15 represents the change in the heart rate, a rise of 15, and the entire acceleration lasts at least 15 seconds. If you have both good variability and accelerations that meet 15-15, 2, and 20, the non-stress test is going to be reassuring. The patient comes to you either because they're high risk or because they have decreased fetal movement. This is where you start. High-risk patients will be screened before there's a problem. Decreased fetal movement is in response to what mom feels. The diagnosis is going to be made using variability and accelerations. If you are greater than 32 weeks, it's 15-15. If you're less than 32 weeks, it's 10 and 10. Both are 2 and 20. The treatment is going to depend on whether or not it is reassuring. If you have a reassuring NST, you can stop. And stop means for decreased fetal movement, reassurance alone. For high-risk pregnancies, come back next week. If it is non-reassuring, you're going to repeat the process with vibroacoustic stimulation and interpret that exactly as you did the non-stress test. So the non-stress test can be done with and without vibroacoustic stimulation. That covers the first 2 of 4 testing, NST and vibroacoustic stimulation. The third is the biophysical profile, and the fourth is contraction stress test. Let's talk about the biophysical profile next. The biophysical profile is also done without contractions. And it is effectively just like the APGAR score after delivery, but it uses different elements. You're going to do the biophysical profile if there is a failed NST with vibroacoustic stimulation. You'll use an ultrasound to look at baby, to determine orientation, to screen for genetic diseases, to see if there's multiple gestations. But most of the time, we don't calculate a biophysical profile. But what we're going to do is use the results of the NST. We're going to look at the amniotic fluid index, and then we're going to look at baby. Breathing, movement, and tone. Very similar to the APGAR, and as is the scoring system where you get 0 to 2 points. And what you do is sum each of the 5 elements. And you're going to make your treatment decision based on what the total biophysical profile is. 8 to 10 is reassurance. 0 to 2 is fetal demise. This is going to be emergency C-section. And in between, you're going to use the gestational age to decide the next move. How do you do the amniotic fluid index, you ask? Well, what is that? What you're going to do is divide mom into 4 quadrants. And each of the 4 quadrants, you're going to get the maximum depth of amniotic fluid. And then you're going to sum all 4 together. And you're going to get a number. Normal is considered greater than 5. What you want to see, that is what is reassuring, is 8 to 25. Pathologic values are going to be too little, oligo, which is less than 5, or too much, poly, greater than 25. Amniotic fluid comes from baby. Baby is supposed to ingest it, swallow it down the GI tract, and poop it out as meconium. Baby is also supposed to get blood flow from mom, and the urine baby makes creates the amniotic fluid. Oligo is a sign of problem with the kidneys. Poly usually a sign with a problem of the gut. But also, when you induce labor or when you rupture the membranes and all of the amniotic fluid comes out of mom's vagina, you're going to see oligo. Last is the contraction stress test. The contraction stress test is going to be used while there are contractions. This is usually done in the setting of labor, not induced for a failed biophysical profile. What you're looking at is decelerations and the presence or absence of fetal bradycardia. The patient will either just be monitored in labor or will have failed her biophysical profile. What you're going to do is hook up a fetal heart tracing and look at it. You still want to see accelerations and variability, and you don't want to see bradycardia. But there are 3 decelerations you need to be able to identify and know what they mean and what you need to do about them. In order to be considered adequate, there have to be contractions, and you need to have 3 contractions in 10 minutes. And ideally, we'd have the force of the contractions, which is 200 Montevideo units. We covered that in normal and abnormal labor. Again, labor. So what we're going to do is compare, and these are supposed to be equal humps and equal in each graph, 3 contractions to what happens to the fetal heart rate. Early accelerations are what happens when the decelerations mirror the contractions. That is, the peak of contractions occurs at the exact same time as the trough or the valley of the fetal heart rate. This is an early deceleration and represents head compression. This is the most benign and requires no action. If what you have instead are fetal heart tracings that have nothing to do with the contractions at all, these are variable decelerations. They are a result of cord compression. And while that sounds dangerous, it isn't. You don't have to do anything with this either. The one you must be able to identify, the thing that makes the CST positive in a negative way, is either fetal bradycardia or late decelerations. And late decelerations look like they start when contractions peak. That is, the peak of contraction is near the onset of the deceleration, and the valley of the deceleration is shifted from the contraction. This is a late decel and represents uteroplacental insufficiency. This is an indication to get baby out immediately. How you get baby out will depend on how far baby is in the delivery, whether you can use forceps, induction, or C-section. What I want you to learn is if late decels and bradycardia, emergency C-section. Okay, so we started off with an algorithm that's pretty easy, right? It just goes from non-stress test with vibroacoustic stimulation, biophysical profile, CST. What you need to identify is be able to see what good variability means, know that fetal heart rates should be between 110 and 160. You want accelerations, 15, 15, 2, and 20. You don't want decelerations, but the only deceleration that actually is problematic is a late decel uteroplacental insufficiency. The biophysical profile makes for great test fodder, but because it requires an ultrasound and an NST, and it doesn't really help you all that much, you might see it on the test, but you're probably not going to use it all that often on the wards. The goal of all of this is to weigh the difference between fetal demise in utero versus more time to mature in utero. That is antenatal testing.